Part 5 of GI disorders is about esophageal atresia. And as you know, atresia means undeveloped. So take a minute and look at this cartoon, because this is what esophageal atresia looks like. So the atresia is a pathological closure of the esophagus, and it's usually hollow. So instead of it going from the epiglottis all the way down into the stomach, it's a blind pouch. Now we can also have a tracheoesophageal fistula along with that, and what happens here is the esophagus ends, but it connects partially to the esophagus, and you can see on the bottom we have grade 1 all the way to 3C. And although this is really difficult to read what the words are, but you can see a nice picture of the defect. And the most common form is the atresia with a distal tracheoesophageal fistula. So the other half of the esophagus is connected to the trachea. So what do you think the presentation is going to be like, and when are we going to see it? Well, we call the classic presentation of a TEF is choking, coughing, and cyanosis. If they only have esophageal atresia and the other part of the esophagus isn't, neither part of the esophagus is connected whatsoever to the trachea, then all that's going to happen with this kid is they're going to take in formula and they're going to vomit, but they're going to be at risk for aspiration. But a kid who has a TEF, they're going to be taking in milk or water or formula, whatever we're giving them. They choke on it, they cough, and they become cyanotic because it's going straight right into the lungs. So the symptoms usually occur at birth or shortly thereafter. Now we do add a fourth C, and what it is copious oral and nasal secretions, as in this kid is constantly drooling because there isn't anywhere for the fluid to go. They may end up with the aspiration pneumonia or pneumonitis, and so they would be showing signs and symptoms of respiratory distress. They can have abdominal distension, and their belly is all full of air. And how do we diagnose it? Well, we're trying to put an NG tube down, and guess what? It's not going anywhere. And so then we'll have the kid go down to radiology, and they'll actually visualize it. So we do surgical repair, and it can be a one-stop shop, or they might have to do a little here and a little there. So it does require a thoracotomy, so it's an open procedure. They might even be doing some of this stuff through a scope at this time. But they cut the connections to the trachea. They put in a G-tube for feedings, and we're going to let this kid grow and gain weight for about 2 years, and then they can use a part of the transverse colon to connect the esophageal pouch to the stomach. Pretty cool, huh? But you can see more about what it's like to have a child with esophageal atresia and TEF by going to this YouTube and hearing about Abigail's story. It's about 5 or 6 minutes long, but it's very good, and there's some good x-ray pictures. This ends the lecture on esophageal atresia.